So the next thing that comes is ST elevated MI. So basically defined as new ST elevation or new left bundle branch block with acute typical cardiac chest pain. So the new guidelines from NICE 2013 says primary PCI in the first 120 minutes, like in the first 2 hours, primary PCI must be done. When PCI not possible within 120 minutes, offer fibrinolysis lysis. The patient present within 12 hours, fibrinolysis. When treating people with fibrinolysis, give an antithrombin at the same time. So antithrombin and fibrinolysis. We'll get to that, like what exactly happens. Offer PCI to patients presenting more than 12 hours with ongoing ischemia, pain or dynamics changes or arrhythmia or in cardiogenic shock. So PCI for these people more than 12 hours but with some complications. Give patient ticagrelor 90 mg BD for 12 months, aspirin 75 mg and statin for life in the absence of contraindication. So for ST-related MI, start with PCI, primary PCI, and also ticagrelor for 12 months and aspirin as well. So these are some important things that are coming up. Coronary circulation, the artery supply of the heart. So posterior aortic or coronary sinus to left common coronary artery, LCA left main, and then divides into LAD and left circumflex. So when you go through anatomy, that's where you will see all these things in details. LCA divides into LAD and circumflex, and anterior aortic or coronary sinus, right, RCA. It's divided into RCA is dividing into posterior descending, and it also supplies SA node, which is a very important one. SA node 60%, AV node 90%, so it's very important. Inferior MI is a common cause of heart block that does not require long-term treatment. Permanent pacemaker as revascularization corrects the heart block. So basically inferior MI does not require long-term treatment because it's basically the SA node has been supplied by the RCA. So fixing the whole issue will be good enough. You don't need a pacemaker. Revascularization would be good enough. Venous drainage of the heart. Coronary sinus drains into the right atrium. Okay, so the very important thing that you need to really remember is like which segment of the heart is supplied by what, which artery. Anterior septal is changes you'll see in V1 to V4. Left anterior descending artery supplies anterior septal muscles. Inferior 2-3 AVF, very commonly presents right coronary artery, which supplies SA node and AV node as well. Anterolateral V4 to 6, that's in the lateral side of the chest, those leads, and 1 and AVL, all of them are in the lateral sides. Left anterior descending or left circumflex. Lateral 1 AVL V5-6, even more lateral. This one is anterolateral, so like at the septal region and also the lateral region. This one is totally lateral, left circumflex. Okay, posterior tall R waves in V1 and usually left circumflex, also right coronary. Okay, what's next? Okay, all patients should be offered the following drugs. This is for, let's remind again, this one STEMI. So all patients should be offered the following drugs: ACE inhibitor, dual antiplatelet must, beta blocker, statin. And what about this? Mineralocorticoid receptor antagonist, MRA, that is spironolactone. Patients who have had an acute MI and who have symptoms or signs of heart failure and left ventricular systolic dysfunction, treatment with an aldosterone and proconist license for post-MI treatment should be initiated within 3 to 4 days of the MI, preferably after ACE inhibitor therapy. Alright. So it's also recommended. So when we said fibrinolysis along with PCI, what was it? Fibrinolysis along with antithrombin. So what was the fibrinolysis about? So here, fibrinolysis or thrombolysis is the same thing. Tissue plasminogen activator has been shown to offer clear mortality benefits over streptokinase. So we don't really give streptokinase anymore. Tenecteplase is easier to administer and has been shown to have non-inferior efficacy to alteplase. With a similar adverse effect profile, and ECG should be performed, so that's what we do. Like we go for tenecteplase and is easier to administer. Okay, an ECG should be performed 90 minutes following the thrombolysis to assess whether there has been a greater than 50% resolution in the ST elevation. So that's what we look for, like ST elevation resolution, 50 more than 50%. So after the thrombolysis, that's what we do. The thrombolysis with tenecteplase and or alteplase, depends. Tenecteplase is like preferable. If there has been not adequate resolution, then rescue PCI is superior to thrombolysis. So that's what we do, rescue PCI again. For patients associated with thrombolysis, PCI has been shown to be beneficial. So what are the contraindications to thrombolysis? When would you be worried about doing thrombolysis? If there's an active internal bleeding or recent hemorrhage or trauma or surgery, coagulation, bleeding disorder, intracranial neoplasm, stroke, of a history of stroke less than 2 months ago, aortic dissection, recent head injury, pregnancy, severe hypertension, that's when you don't want to do a thrombolysis. Okay, restless syndrome. What is that? Restless syndrome is a type of pericarditis. It's believed to be an immune system response that usually occurs 1 to 8 weeks after MI. So it's a post-MI immune response, which might be dangerous as well. The presentation might be malaise, fever, pericardial pain, increased erythrocyte count, and ESR. Sometimes may also have pleuritis and pneumonitis. It has been postulated that the syndrome results from release of cardiac antigens, which then stimulate antibody production. So yeah, it's like an immune response. The immune complexes are then deposited in the pericardium, pleura, and lung. There may be accompanying pleural and pericardial effusion, and therefore echocardiography should be done. Okay, so there are immune complexes, antibody produced against antigens of cardiac muscles. It's deposited in the pericardium, pleura, and lung. So what is the treatment? Involves aspirin and analgesics. Corticosteroids and NSAIDs are best avoided in the first 4 weeks after MI, as they delay myocardial healing. Very important. Can't give these things. Aspirin in large doses is effective. Recurrences can occur, and in such cases, colchicine is helpful. So the much talked PCI. What is PCI? So PCI is a technique. PCI is a technique used to restore myocardial perfusion in patients with ischemic heart disease, both in patients with uncontrollable stable angina and ACS. Stents are implanted in around 95% of patients, and it's now rare for just balloon angioplasty to be performed. So 95% of the patients are having stents implanted during the PCI. Okay, coronary angiography, CAG complications. What is it? The most common one is vascular complication. Overall, is hemorrhage from the access site where you start the thing. Right radial or right femoral artery is mostly used. So hemorrhage from the access site is very common. Less commonly, dissection or rupture of coronary artery during PCI, or rupture of any artery from access to target artery. So anywhere near the pathway, if there is any rupture. So the other complications are contrast-induced AKI, kidney injury, or higher incidence in diabetic patients and patients known to have renal dysfunction, prevented by good hydration. Then cholesterol embolization can happen. Arrhythmias can happen, like arrest and ventricular and supraventricular arrhythmia. Especially in primary intervention in case of MI, allergic reaction to contrast may happen. Following stent insertion, migration and proliferation of smooth muscles and fibroblasts occur to the treated segment. So there will be smooth muscle growth actually. The stent struts eventually become covered by endothelium. Until this happens, there is an increased risk of platelet aggregation leading to thrombosis, hence dual antiplatelets needed. So this is why the dual antiplatelets are playing a role here. The smooth muscle growth happens, and eventually they are covered by endothelium. Until that, there is an increased risk of platelet aggregation, which can lead to thrombosis. As a type of stents that are there, bare metal stents, BMS, or drug-eluting stents, DES, stent coated with paclitaxel or rapamycin, which inhibit local tissue growth. While this decreases restenosis rates, the stent thrombosis rates are high, as the process of stent endothelialization is slowed. So this might actually cause some more problem. sometimes. BMS in type 2 diabetes mellitus raised stenosis risk in 6 months is 40 to 50%, very high. So the complications are that there are stenting complications. So the two stenting complications can be stent thrombosis, basically due to platelet aggregation, occurs in 1 to 2% of the patient, most commonly in the first month. So this is happening like very early onwards, very early onset, first month. Usually presents with a new MI of same territory, restenosis due to excessive tissue proliferation around stent. Restenosis occurs in 5 to 10% of patients, mostly occurring in the first 3 to 6 months. So stent thrombosis in the first month, restenosis in 3 to 6 months, mostly with BMS, bare metal stent. Usually present with the recurrence of angina symptoms, risk factor include diabetes, renal impairment, and stents in venous bypass grafts. Okay, overview of cholesterol embolism. That was one of the complications. Cholesterol emboli may break off, causing renal disease. Seen more commonly in arteriopathy, abdominal aortic aneurysm. Features might be eosinophilia purpura, renal failure. Levator reticularis is a common cutaneous finding consisting of a mottled reticulated vascular pattern that appears like a lace-like purplish discoloration of the lower extremities caused by swelling of venules in the skin, which makes them more visible. Okay, like what are the primary and secondary prevention in CVD, cardiovascular disease? Let's see. Okay, identifying, assessing risk. High risk are type 1 diabetes, CGFR less than 60, albuminuria, history of cerebrovascular disease, cardiovascular disease, family history. Key risk to assessment tool is used to assess CVD risk for the primary prevention of CVD. Key risk tool will underestimate risk in people who have additional risk because of underlying condition treatment. The risk group include more than 85 years of age, BMI more than 40, HIV, serious mental health problem, medicine that can cause dyslipidemia such as antipsychotic medication, corticosteroid, immunosuppressant, autoimmune diseases like SLE, hypertension, recently stopping smoke. This might underestimate these people. Okay, the lipid modification therapy for the primary prevention of CVD. Okay, check lipid profile before starting lipid modification therapy. So we have to start before starting the modification therapy, lipid modification therapy. We should start the lipid. We should check the lipid profile. Total cholesterol, HDL, non-HDL cholesterol, triglyceride concentration. Fasting is not very important. Atorvastatin 20 mg should be offered for the primary prevention of CVD. Okay, estimate the level using QS tool. So this is the primary prevention, and secondary prevention is when a person already has an episode of CVD. If a person has CVD, secondary prevention atorvastatin 80 mg and primary is 20. You need to remember that. A lower dose of atorvastatin may have potential drug interaction or increased risk of adverse effect. Total target cholesterol and follow-up. 40% reduction in the baseline non-HDL cholesterol in 3 months is target for primary and secondary prevention. If not achieved, discuss adherence and timing of dose or optimize adherence to diet and lifestyle measures. Consider increasing dose if started on less than atorvastatin 80 mg and the person is judged to be at high risk. Ezetimibe co-administered with atorvastatin can be considered for people with primary hypercholesterolemia. Going to a new topic, cardiac arrhythmia. Very important topic, cardiac arrhythmia. So things that come up firstly is supraventricular tachycardia. While strictly speaking, the term supraventricular refers to any tachycardia that is not ventricular in origin, supra as in not ventricular, atrial in origin, or anywhere not ventricular. The term is generally used in the context of paroxysmal SVT. Episodes are characterized by a sudden onset of a narrow complex tachycardia. So SVT is where you see this kind of narrow QRS. Occurs by a sudden onset of narrow complex tachycardia, typically an AVNRT, atrioventricular nodal re-entry tachycardia. So these re-entry of signals. 85% of SVT is AVNRT, and it's conducted by an accessory pathway that passes through the AV node This causes more signals. Other causes include atrioventricular re-entry tachycardia (AVRT) and junctional tachycardia. So this is what you see in ECG for SVT. You see that the QRS are very narrow and the heart rate is high. Acute management, what would you do for this? Vagal maneuvers, Valsalva maneuver. If patient is hemodynamically stable, you give adenosine 6 mg, then 12 mg, and then 12 mg. Use with caution in asthmatics. Paracetamol as a preferable option for flow response. Consider electrical cardioversion. So this is for SVT, very important. And prevention of episodes. What do you do for prevention? Beta blocker, flecainide, and radiofrequency ablation is a therapeutic measure, over 90% success rate. So this is a good option for SVT people like patients with recurrent SVT. Okay, automatic supraventricular tachycardia, atrial tachycardia, a form of SVT that does not include an extra pathway. Like for SVT, there was this reason like AVNRT, atrioventricular nodal reentry tachycardia is this pathway. This one. So here for automatic one, there's no pathway involved. The impulse is generated from the atrial cells other than sinus node. There are some other cells which will generate some signals. Commonly we'll be able to see P wave with abnormal P wave morphology, usually characterized by warm-up phenomenon where the rate gradually increases after initiation. It's retrograde P wave in AVNRT. Cardiac arrhythmia is a very commonly asked questions topic. In other forms of SVT, rate fires at high speed from begging and mostly impossible to see P waves before the QRS. In AVNRT, you may see a retrograde P wave at the end of the QRS or shortly following the QRS. So that's where you see the QRS here. The P is like following the QRS, so that's something different. Okay, for premature ventricular contractions, usually insignificant unless occurring frequently, more than 6 beats per minute, bigeminal rhythm, short runs of VT, R&D phenomena associated with serious organic heart disease, left ventricular decompensation or decompensated heart failure. Okay, the next topic is very important, atrial fibrillation. Almost every time there are questions from AF. It's basically a supraventricular origin as well. Supraventricular tachyarrhythmia characterized by ineffective, chaotic, irregular, that's the most important thing, and rapid 300 to 600 beats per minute atrial activity, resulting in the deterioration of atrial mechanical function. Luckily, ventricular contractions in AF does not follow the same rate. So in atrium, the beats are 300 to 600, but in ventricular contractions are not following that rate due to slower contractions of its fibers. Hence, heart rate in AF does not reach 300-600. AF is the most common sustained cardiac arrhythmia seen in the general population. So what is the pathophysiology? What's happening here? In majority, it's caused by rapidly firing cells in the left atrium located at the junction of the pulmonary vein. So pulmonary vein comes together and then there's this left atrium. So at the junction, there are some rapidly firing cells. The rapidly firing impulses are disorganized and cause irregular atrial depolarization. So and ineffective atrial contractions. The contractions are not really effective. They're ineffective and there's like irregular depolarization of the cells, and in turn it results in an irregular ventricular rate as well, because the impulses from the atria approach the AV node and from varying angles and at varying intervals. So these impulses are approaching the AV node from different angles, different intervals. So it's like the ventricular rate is also irregular. It is good to see an ECG of AF. It's not AF. So what are the causes of AF? AF is seen in the elderly and generally is asymptomatic. This is thought to be due to age-related fibrosis or muscle fibers in left atrium. Okay, large or dilated left atrium. Long-standing hypertension causes. Okay, what can cause large or dilated left atrium? Long-standing hypertension can cause stiffness of the left ventricle, of course. This is a diastolic dysfunction. This in turn makes the left atrium ability to feel the LV So this in turn makes the left atrium ability to feel the stiff left ventricle more difficult and require more power or pressure, resulting in dilatation of the left atrium. It's like something that takes, that happens over time. Hypertension is the most common cause of AF, so this is something very important. So yeah, mitral stenosis makes the ability of left atrium to feel LV even more difficult, resulting in dilatation of the LA. So this is like the main reason why it's happening, and it's followed by, like in this mitral stenosis or hypertension, it's followed by this, and this is usually severely dilated and cause stasis of blood in left atrium, resulting in higher incidence of thromboembolism. Constitutional disorders like thyrotoxicosis, sepsis, and infection can cause AF. And now lifestyle like obesity, metabolic syndrome, sleep apnea, psychological stress, alcohol, and high caffeine intake can also cause it. Genetics are thought to play a role as well as tall stature, supraventricular arrhythmia, including AF, secondary to acute alcohol intake, are well recognized and have been termed holiday heart syndrome. For this, there is no specific treatment required. Alright, now AF classification. How do you classify AF is also like a very important question. First detected episode, irrespective of whether it's symptomatic or symptomatic. Recurrent episodes. When a patient has more than 2 episodes of AF, if episodes of AF terminate spontaneously, then the term paroxysmal AF is used. So it's like terminating by itself. Paroxysmal AF. That the AF that benefits most from beta blocker. So this is the one where beta blocker really helps. Such episode lasts less than 7 days, but typically less than 24 hours. If the arrhythmia is not self-terminating, if it's not going away, then the term is persistent AF, and episodes usually last more than 7 days. And permanent AF, continuous atrial fibrillation, which cannot be cardioverted, or if clinicians think attempts to cardiovert are deemed inappropriate or unlikely successful. Treatment goals are therefore rate control and anticoagulation if appropriate. So what are the main 2 things that you want to do here for permanent AF is rate control and anticoagulation if appropriate. To summarize, permanent AF is when physician decides this AF should not be cardioverted. Okay. So next is basically NICE guidelines. Latest 2020, anticoagulation recommendations were changed but not arrhythmia management. So what is the acute management of AF? It's like onset if it's less than 48 hours. If AF is of less than 48 hours, the patient should be heparinized, and transthoracic echo should be performed to exclude the thrombus. So if it's less than 48 hours, you should heparinize the patient, like give heparin and then do an echo. Okay, so like you can remember it like this: give heparin, do an echo. So the thrombus, for example, following this patient may be cardioverted, either DC cardioversion or pharmacology. So you can write DC, HEDC, or HEDCA. Just keep it like that and remember. For electrically, you can do DC cardioversion. Pharmacological, you can do amiodarone if structural heart disease, flecainide in those without structural heart disease. I already wrote it here. Following cardioversion, if AF is confirmed less than 48 hours, then further anticoagulation is unnecessary. So the only time you do you give the anticoagulant is here in the beginning. Do echo to exclude the thrombus, and then give DC shock or amiodarone or flecainide if there is no structural heart disease. If it's more than 48 hours, what do you do? If AF is of more than 48 hours, then patient should have therapeutic anticoagulation again for at least 3 weeks. So when it's more than 48 hours, we don't just go for echo or all that. So you just give anticoagulation for more than at least 3 weeks. If there's a high risk of cardioversion failure, previous failure or AF recurrence, then it's recommended to have at least 4 weeks amiodarone or sotalol prior to electrical cardioversion. So like if there's high risk of failure of that cardioversion failure, previous failure or AF recurrence, there's a history of AF, Then it's recommended to have at least 4 weeks of amiodarone or sotalol prior to that. 4 weeks amiodarone. So here's the formula: 3 weeks of heparin, 4 weeks of amiodarone. Following the cardioversion, patient should be anticoagulant for at least 4 weeks again. After this decision about anticoagulation should be taken based on individual risks of reoccurrence. Okay, next is what are the type of cardioversion? What do you exactly do? Pharmacological wise, it's amiodarone, flecainide, others like propafenone, clonidine. These are the two main ones. Less effective agents: beta blocker, calcium blocker, digoxin, disopyramide, procainamide. Within tachycardia, any tachycardia, SVT, AF, or ventricular, if patient is hemodynamically unstable with any tachycardia, remember this, with any tachycardia, it can be SVT, AF, or ventricular. If patient is hemodynamically unstable with impaired consciousness, acute heart failure, or acute chest pain, treatment is DC shock as per ALS guidelines. These are like the alarming signs. Okay, non-acute management. Okay, non-acute management either from two large randomized trial shows, rate control and rhythm control. So there's like two way of approaching it. So when do you do what, and also like what exactly do you give for that? Okay, so firstly, factors affecting the rate control, other than favoring the rate control, like which way factors favor the rate control. Older than 65 years old, structural heart disease like large left atrium, more than 5.5 centimeter, mitral stenosis, ischemic heart disease. All these are examples of structural heart disease. And long duration of AF, more than 12 months, go for rate control. Older people go for rate control. So young people, young rhythm, remember that. For factors favoring rhythm control, younger than 65 years old, symptomatic first presentation, reversible cause, congestive heart failure. However, these factors are not absolute. If the patient is more than 65, is troubled significantly by symptoms of AF, and rate control proven to be difficult, rhythm control is considered adequate. So if in case rate can't be controlled, you go for rhythm control. How do you control rate? Of course, beta blockers are handy here. Calcium channel blockers are also handy. Digoxin, but digoxin is like preferable for patients in heart failure. That's better for them. And for rhythm maintenance, that's you go for SAF, that is sotalol, amiodarone, flecainide. And then of course the stroke risk is there for AF patients. So what do you do for stroke prophylaxis? Antithrombotic therapy should be considered using the same criteria irrespective of the pattern of AF. Valvular AF should be treated with vitamin A, warfarin, vitamin K antagonist. With valvular AF, according to the European Society, only refers to patient with moderate to severe mitral stenosis, prosthetic heart valves, all that. Non-valvular AF, the guidelines suggest stroke risk stratification approach when determining when to coagulate a patient as little below. So there's like a way to determine if whether you want to give a patient anticoagulation or not. So that's where the Schatz-VAS score comes up. It's recommended by NICE to estimate stroke risk in patients with non-valvular AF. So what are the things that are here? C for congestive heart failure, it gets you 1 point. Hypertension, 1 point. Age more than 75, 2 points. Age 50 to 74, 1 point. Diabetes, 1 point. Prior stroke or TIA, 2 points. Vascular disease, 1 point. Female sex, 1 point. So the table shows anticoagulation strategy based on the score. No anticoagulation required, 0. Score 0, no, it's not required. Score 1, consider anticoagulation for men with score of 1. 2, anticoagulation. So it's like very easy to score, I think. Like if it's like a complicated patient with a history of stroke, already you need to do anticoagulation with if he or she is having AF. Anticoagulation may be apixaban, dabigatran, rivaroxaban, or vitamin K antagonist. Discuss the options with the anticoagulation. Do not offer aspirin monotherapy solely for stroke prevention to be cured with AF. Consider left atrial appendage occlusion if anticoagulation is contraindicated or not tolerated, and discuss the benefits and risk of the LAAO with the person. Do not offer LAAO as an alternative to anticoagulation unless anticoagulation is contraindicated. You should also determine the Hasbled score. for the reduces the risk of bleeding in patients who are having anticoagulation. So now what's the Hasbro score? Remember, this is very important. 2, you give anticoagulation. 1, if the patient is a male, go for anticoagulation. 0, no need. So for Hasbro score, what is this? It's recommended by NICE to calculate the risk of bleeding in patients with AF. Okay, so Hasbro age is for hypertension, gets you 1 point. A for abnormal renal function, 1 point. Abnormal liver, cirrhosis or bilirubin more than 2 times of normal, and AST, ALT more than 3 times of normal, gets you 1 point. Stroke 1, bleeding history 1, labile INR 1, LLA 1, drugs that risk increase bleeding risk or alcohol 1. Alright. So it's a lot of things. So if Chadva's score is 3 and Hasbel is also 3, so if it's like the Chadva's score, whether you give anticoagulation or not, and Hasbel score whether there's bleeding risk or not, is both like equal. It does not mean we should not anticoagulate, as the stroke risk is always higher and impact of stroke on lifestyle is usually worse. GI bleedings, for example, are potentially treatable. So what they're trying to say, if like they're equal, the Hasbel score and the Chadva's score, the stroke's risk is even worse than bleeding risk. Stroke will eventually impact the lifestyle and everything. GI bleedings they're treatable, so better to anticoagulate the patient. DOAC has a lower risk of intracranial bleeding compared to warfarin, so like the oral anticoagulant drugs, but their reversal agents in case of life-threatening bleeding is not widely available. So the decision about not to anticoagulate should always be personalized to specific patient and should always be discussed with patient and or family. Many clinicians will not anticoagulate patient based on their judgment that anticoagulation would put patient at high risk of bleeding due to falls. However, 2014 guidelines clearly stated do not withhold anticoagulation solely because the person is at a risk of having a fall. Statistically, 295 falls are required in an anticoagulation to cause one intervention, so that's like very low risk. So must anticoagulate. Still a lot of arrhythmia topics left.